Um, so today's class is upon mitral stenosis, a postdoctoral guide. As per the information given, today we will cover the anatomy, physiology, pathophysiology, and as part of the anesthetic consideration that we take care of when we are dealing with a patient with mitral stenosis. So first we come to a case presentation. Just a minute, please. Let's see. Yes. Uh, a patient, Sarifan Bibi, 26-year-old female patient, presented with a complaint of gradually increasing breathlessness for the last 10 months. The breathlessness was gradually progressive in nature, exertional type, and non-seasonal in nature. Cough was, her breathlessness was not associated with cough or with rise of temperature. She also had a history of easy fatigability for the same duration. Along with that, she had no history of palpitation, chest pain, swelling of legs, syncope or squatting, pain in legs during walking, or any neurodeficit. 2 weeks back, she experienced an episode of acute respiratory distress at the middle of the night, which was sudden in onset, lasted for about 45 minutes, and was relieved upon sitting upright and standing near the window for fresh air. She was
Just a minute, Priyanka, can you share your screen as a whole full screen? And it is not moving, I think. We are just seeing the first slide only, not the
Yes,
second,
ma'am.
third
I'm
slide.
reading the first slide still now.
Okay, can you make the screen full screen? That is the full, I think it would be clearer.
Ma'am, I'm.
Probably she has not written everything there.
Okay.
Okay,
No,
it is there.
Is this okay?
yes,
Hmm.
it is. It is.
Yeah,
Yeah.
I have actually kept, this is not a detailed, very detailed history. I have just kept it, tried to kept only relevant information just for the
Okay, fair enough. Fair
time.
enough.
Yeah.
Exactly, fair enough.
So 2 weeks back, she experienced an episode of acute respiratory distress in the middle of the night. And that episode was sudden in onset, lasted for about 45 minutes, and relieved upon sitting upright and standing near the window. She has no history of hypertension or diabetes or contact of with tuberculosis or any exposure. After that event, she was brought to our hospital OPD, and hence then she has been under medical treatment for the past 8 months. She had an uneventful history of childbirth 4 years back. She had definite history of joint aches, which affected in her childhood, which affected mainly the big joints like knee, ankle, and elbow, following an attack of sore throat. The pain was fleeting in nature and was not associated with any skin lesion or chorea. So on examination of that patient, the general survey revealed she had no anemia, icterus, clubbing, cyanosis, edema, or
1 minute, Priyanka.
Yes, ma'am.
Priyanka, till now, what is your diagnosis, provisional diagnosis, till now from the history?
From the history,
Anyone else can answer also, not only Priyanka. Okay, Priyanka, answer this question.
My provisional diagnosis would be that this is most likely a case of valvular heart disease, in all probability rheumatic in origin, and which will further be corroborated with other findings, and then I can conclude.
Okay, Shoptoki is there, I think. Shoptoki, can you tell me why she is telling that it is valvular heart disease and not respiratory disease? Shoptoki is there, I think.
Yes, ma'am.
Shoptoki, why it is not a respiratory
Yes, ma'am.
disease? Why it is not a respiratory disease?
Madam, there is a history of exertional dyspnea. Hello.
I can hear
And there
you.
is also history of PN and also history of PND.
History of PND, okay.
Paroxysmal nocturnal dyspnea.
Then? And the dyspnea is, she told it. Before PND, she told it. It is not seasonal, no? Seasonal variation is not there.
Yeah. It is exertional.
So that goes against the respiratory disease, okay?
Yes, ma'am.
Continue, please, Priyanka.
So on examination of this patient, we found in general survey that there was no anemia, icterus, clubbing, cyanosis, edema, or lymphadenopathy. The pulse was 78 per minute, which was low volume but regular, with all peripheral pulses palpable equally in 4 limbs. Blood pressure was 100 by 70 millimeter of mercury, taken in supine position. There was no engorgement of the neck veins nor any pulsatility seen. On examination of the cardiovascular system, we saw that there was no deformity of the precordium, no visible pulsation or scar mark. Upon palpation, we found that the apex beat was in the left fifth intercostal space inside the midclavicular line, which was tapping in nature. Our diastolic thrill was palpable in the mitral area, which was best felt in the left lateral position and in full expiration, and there was absence of left parasternal heave.
How you felt it?
Yes, ma'am.
How you felt it?
By turning the patient, laying the patient supine with the hypothenar eminence of my hand, I to ask the patient to turn towards the left side, and then I felt the apex beat.
Okay.
Upon
Then
auscultation, the first heart sound was short, sharp, and accentuated. The second heart sound was audible, which was preceded by an opening snap just before the S2. There was also a low-pitched mid-diastolic rumbling murmur with pre-systolic accentuation of grade 4 intensity in the mitral area without any radiation. The murmur was best audible at the cardiac apex with the bell of the stethoscope in the left lateral position at the height of expiration. And there was absence of any split, click, rub, or murmur over the other areas. Uh,
so
upon
then
Upon examination of the neurological function and the CNS, there was no history of abnormal jerky movements or weakness of the limb. Higher motor and sensory functions were intact, and there was no neurodeficit. Respiratory system, there was bilateral equal vesicular breath sounds, no adventitious sounds were heard, and other system revealed no organomegaly or ascites, bladder and bowel were normal.
विशाल को बोला पूछने को सर मालूम कितना बोलता रहा 1500 रुपया
who is there? Acha, what about the neurological system?
Ma'am, neurological
that
system,
important?
there was no history of any jerky movements or limb weakness, and higher motor functions were also intact. She did not have any neurodeficit as of now. No prior history of loss of consciousness or TIA or anything.
What else you have to see in neurological system? That is muscle power of all four limbs.
Yes.
How much it is? Okay.
Yes.
4/5 or 5/5 or what is that? Because if there is residual, then you have to tell that. And you have missed something. Up to this, you have missed something, I think. What's that? Have you told about airway? Have you told
Respiratory
about
system, ma'am, respiratory system, I was telling
not
that there was,
airway? Respiratory system, I'm not asking. I'm asking about the airway. Because being an anesthesiologist, we must tell about the airway. No? How is the airway? We must see that either in the general survey or in the systemic examination. Where you have told about airway?
No, not yet, ma'am.
Not yet means you have not checked, but you have to. Okay.
Okay, ma'am.
And in mitral patients, you must check the neurological system.
Yes, yes.
And that is the power of the all four limbs. Okay.
Yes, ma'am.
So what is your provisional diagnosis now?
My provisional diagnosis is still coming to valvular heart disease, most likely rheumatic in origin, and most likely it is mitral stenosis without any signs and symptoms of cardiac failure.
Anything else? You missed that? The patient is in AF or not?
No, the patient is not in AF till now.
So you have to tell that also, no?
Okay. So
what will be your total diagnosis of the patient?
This is a case of valvular heart disease of rheumatic origin without any signs of congestive cardiac failure, and the patient is in sinus rhythm.
Mitral stenosis, you think it is mitral stenosis. Provisional diagnosis, you can tell after the examination, it is mitral stenosis. Provisionally, it is provisionally diagnosed as mitral stenosis without it. Here, there is no atrial fibrillation. So, without atrial fibrillation, without pulmonary hypertension, is it there?
She had one episode of pulmonary.
No, one episode that has been subsided. She is suffering from pulmonary hypertension. No.
No, ma'am.
Then, without pulmonary hypertension, without congestive heart failure, without active rheumatic carditis. Is it there, rheumatic carditis, any feature, fever or something else?
No, currently she is not having any feature of.
Currently, she is not having. So you have to finish your diagnosis in this way. Mitral stenosis. Provisional diagnosis is mitral stenosis without atrial fibrillation, without pulmonary hypertension, without congestive cardiac failure, and without any rheumatic carditis, active rheumatic carditis. But
Okay.
probably this is of rheumatic origin. That completes your diagnosis. Okay.
Okay, ma'am.
So, can you please tell me what are the parts of the mitral valve? Anyone else, not only Priyanka, anyone else? Can anyone volunteer, please? Orgo is there? No.
Yes, I think Orgo is there. Students, please come forward and participate.
Orgo is there. What are the parts of mitral valve?
Ma'am, the mitral valve apparatus as a whole comes.
Who is speaking?
Ma'am, I'm Oishi. I'm a second year postgraduate trainee from Tagore.
Okay, please tell.
Yeah, the
What
mitral
are
valve. The mitral valve apparatus is composed of the left atrial valve, the mitral annulus, the anterior and posterior mitral valve leaflets, and the chordae, and the lateral and posteromedial papillary muscles.
Papillary muscle, chordae, and leaflets. Anything
Leaflets.
else?
And mitral annulus and left atrial
Mitral
valve.
annulus.
Yes.
Okay. You please tell me the parts of the mitral leaflets, anterior and posterior. What are the three classifications? What is the anatomic classification? What is Carpentier classification? What is Duran classification? Can you please tell?
Hello.
Anybody? I can hear. Please carry on.
Hello.
What are the three classes? Please tell me. What are the three classification of mitral valve?
Yes, ma'am. Hello. Can you hear me?
Who is there?
Hello.
Yes. Who is there?
Ma'am, Oishi.
Please tell. What are the three classification of mitral valve?
There's an anatomic classification. There's this
That is
Carpenter.
classical anatomy. Carpentier classification and
Carpenter
Duran classification.
and Duran classification. Yes, ma'am.
So how we will say? Describe three classifications. Can you please?
Ma'am, I
Priyanka, please
can.
complete.
So,
Priyanka, please complete it.
So the anatomical classification is very simple. It just it is only the presence of divided into the anterior mitral leaflet and the posterior mitral leaflet. The Carpentier classification is similar to the anatomical classification, where the division is done. The anterior and the posterior leaflet is divided into three parts: A1, A2, P3. This division is basically
A1, A2,
on the
A3, not A1,
scallops.
A2, P3.
A1,
A1,
A2,
A2,
A3
A3
and P1, P2,
and P1,
P3.
P2, P3.
The division is
Yes.
basically dependent upon the scallops of the posterior mitral leaflet, like in P1, P2, P3, and the anterior mitral leaflet is nomenclatured just whichever part is lying corresponding to its posterior mitral leaflet. That P1, the part of the anterior mitral leaflet opposite to the P1 is A1, opposite to P2 is A2, and opposite to P3 is A3.
A3 is
And
P3.
the Duran's classification is a little bit different from the AAC or the Carpentier classification, which actually is determined depending upon which part of the chordae is attached with which papillary muscle. So here the classification changes as commissurals are coming from the commissure it is starting. So commissure is started as C1, following which the anterior mitral leaflet is divided into two parts, A1 and A2. Then we have the C2, that is the posteromedial commissure, and then the posterior mitral leaflet, instead of dividing into P1, P2, P3, it is divided into P1, posteromedial part 1, posteromedial part 2, and the P3.
Okay. Then what is the mitral valve area? How will you classify the mitral stenosis?
Normal mitral valve area is 4 to 6 centimeters square. Symptoms appear when the mitral valve area reduces below 2.5 centimeters square. And as from the echo-based criteria, if the mitral stenosis is more than 0.25, it is mild. From 2.5 to 1.5, it is moderate, and below 1.5 mitral area is considered to be as severe.
Okay. According to gradient, you didn't go there. You have written it.
Eco gradient wise, we have valve area, the pressure half time, the mean gradient, and the PASP, that is the pulmonary artery systolic pressure. If the valve area is more than 2.5, pressure half time is less than 100, mean gradient is less than 5, and pulmonary arterial pressure is less than 30, then it is mild. If the valve area is between 2.5 to 1.5, PHT is between 100 to 150 with a mean gradient of 5 to 9 millimeter mercury, and PASP between 30 to 50, it is moderate. And if the valve area goes below 1.5 with a PHT of more than 150 with a mean gradient of more than 10 and a PSP of more than 50, then it is classified as severe mitral stenosis.
Okay. What are the hemodynamic changes in mitral stenosis? Hemodynamic changes in mitral stenosis.
In mitral stenosis, ma'am, the entire pressure volume loop that we have, it basically shifts below and leftward. So our the entire thing, if once the curve shifts to the below and leftward, then we see that our preload decreases because because of the increased gradient between the LA and the LV. There's a decrease in the preload, which will subsequently decrease both the end diastolic LV systolic volume and the NV systolic pressure. Because of less filling, there will be a decrease in the contractility and the stroke volume of the patient. And yes, and because the LA pressures are rising, we will see a rise in the backward
Please
flow.
describe. Then
We will see a rise in the LA pressures, which will cause a subsequent rise in our pulmonary arterial pressure, and following which the RV pressures and the RA pressures will also rise.
okay. So what will happen when the heart rate will increase?
When the heart rate will increase, because it is a obstruction to our forward flow, the heart will not have enough time for the diastolic filling. So, and also because the raised LA pressures, as the atria stretches, it may, and if the patient is not in sinus rhythm, so it will also lose its it will lose its atrial contractility period. So that will worsen our forward flow, even worsen our forward flow, which will cause less filling and less less ongoing of the blood from the LA to LV, less time for the diastolic filling, loss of the atrial contraction, and ultimately result in hypotension of the patient.
Hypertension of the patient. Anything else? Anything else happens there? What will happen to pulmonary pressure? Pressure, what will happen to that?
Increase, ma'am.
Raised. Who is
Yes,
there?
ma'am.
Who is speaking?
I'm
Who is-
Dr. Ahmed, ma'am, second year, PGT from Eye Care Haldia.
Eye Care Haldia, okay. PA pressure will rise. Okay.
Yes,
And what will happen if there is AF?
there will be chance of, ma'am, thromboembolism.
I am asking about the hemodynamics, then I'll go to the thromboembolism part. Priyanka, what will happen if there is AF?
If there is AF, then our diastolic filling will be impaired, because in diastolic filling, the transmitral through the transmitral flow, we have that E and A. So the A part will be lost. So there will be impaired diastolic filling in AF. That will cause a stasis of blood in the LA part, which will cause presence of
Formation
ACC.
of? Which will
Formation of ACC, and subsequently LA clots may be formed,
LA clot.
which will
Yes.
further, which on further contraction, or in case of forward flow, we can have risk of our embolism or stroke will increase.
Yes.
Just one comment, madam. What is the effect of atrial fibrillation on cardiac output? Can you tell what is the contribution of the atrium to our cardiac output? So this will also decrease. So how much cardiac output will be
30%
reduced?
of the diastolic filling
Very good.
depends
Very
on
good.
the atrial contraction.
Very good. So cardiac output will be 30% less if it is a atrial fibrillation.
Atrial fibrillation. Okay. What is the first symptom of MS and why?
Ma'am, the first symptom of MS is dyspnea, because
Why?
all the symptoms pertaining to mitral stenosis is depending upon the rise of the LA pressures. So rise in the LALV gradient will that is the increase in the left atrial pressure will subsequently impart has hazardous effect on the pulmonary vasculature, and thus the first symptom that we get is dyspnea, which is commonly exertional in the nature.
And there is, when the patient will walk, there is fixed cardiac output, cannot
Yes.
increase the cardiac output, na?
Yes.
So, what is the size of the
Because of the
valve that will
fixed,
cause the symptom?
yes, ma'am.
What is the size of the valve that will cause symptom? That will cause symptom with
Less than
exertion.
2.5 centimeters square
And
will
that,
slowly progress
and
to
what is
symptoms.
the size of the valve when symptoms will occur at rest also?
Less than 1.5 centimeters square.
Yes, good. What is PND? Why it occurs?
Paroxysmal nocturnal dyspnea is PND. This happens when the mitral stenosis has progressed in severe mitral stenosis. That is basically patient typically complains of respiratory distress on lying down, that is in supine position. Because of the
Why in supine position,
backward
respiratory
pressure,
distress?
on supine position. From the LA pressures, there is a sudden rise in the pulmonary pressure of the pulmonary vasculature due to pulmonary arterial.
Why? I am asking why.
Due to
Why?
pulmonary venous hypertension and
Why? Why? What will happen? What will happen? Why when the patient lies down?
ma'am, on lying down, there will be there will be backward flow of the blood into the pulmonary vasculature because of the pulmonary venous hypertension.
What will happen to the venous return?
Venous return will decrease, ma'am.
When the patient will lying down, will lie down, patient venous pressure will decrease. Venous
Ma'am,
return will decrease.
venous return will increase, ma'am, when patient will lie down.
Yes. So what will happen?
There will be increased RF filling, increase overload on the heart. So once forward flow is also restricted, LA to LV flowing is not there, as well as RA is receiving more of the blood. So ultimately will cause more respiratory distress on lying down.
Ultimately there will be respiratory distress. Increase in LA pressure. Increase in LA pressure will cause retrograde increase in the pulmonary venous pressure, and then interstitial edema causing this pulmonary edema and the dyspnea. What are the other symptoms of mitral stenosis?
Ma'am, easy fatigability is another complaint that is basically
Low
because
cardiac
of the low
output.
cardiac output. And then we have palpitations most because once arrhythmia settles in, then patients complains of palpitation.
Then any other complaint? Orthopnea will be there or no?
Yes, ma'am.
Orthopnea will be there.
In progressed cases, orthopnea.
Yes, orthopnea will be there. Then chest pain will be
There
there.
may be associated, yes, chest pain. There may be
chest pain due to. Why there will be chest pain? Maybe because of coronary embolism or associated coronary artery disease.
Yes.
Or that may be due to RV angina. So why there will be dysphagia can be there?
Yes, because of the LA enlargement posteriorly, there can be associated complaint of dysphagia also. Swelling of
syndrome. What is Ottner's syndrome?
Recurrent laryngeal nerve compression by the enlarged LA.
Yes. So there will be Ottner's syndrome also. All these are the symptoms of mitral stenosis.
Ma'am, also there will be the symptoms of hemoptysis because of the rupture of the pulmonary vasculatures.
That can also be there. Okay. So what is malar flush? Can anyone tell what is malar flush? Though we don't see it, malar flush.
Ma'am, in severe mitral stenosis, when there is fixed cardiac output, there is central cyanosis, and the malar region, they get flushed, like pinkish purplish patches will appear. That happens in case of severe stages of mitral stenosis where there is vasoconstriction and like peripheral cyanosis can be seen on the
Vasoconstriction, it is not vasoconstriction, it is vasodilatation with chronic
vasodilatation
low
over the
cardiac
malar
output. It is-
area, only over the
Yes.
malar area, but other parts can present with central cyanosis like features.
Yes, but the malar area, there will be vasodilatation with chronic low cardiac output. There will be malar flush. Okay.
Yes.
So, why apex bit is lateral in these cases, mitral stenosis?
Because of the like mitral stenosis, there is associated RVH of this patient, which pushes
RV pushes the LV
outward.
outward or posteriorly. Okay. So, can you tell me when you will listen the opening snap?
Opening snap is heard just prior to the S2. Opening snap
Prior to S2, ঠিক করে বলো। Prior to S2 or after S2? Opening snapটা কখন হবে? Anyone else? When the opening snap will occur? Anybody else?
Ma'am, just
It's-
immediately after the second heart sound.
Yes, immediately after the second heart. So S1, S2, OS, then S1. Again. Okay, what is the time of what is the duration of a opening snap?
The duration, according to the duration of S2, if the duration of the opening S2 and OS opening snap gap decreases, the severity of the MS is more MS of the severity is more severe. The MS is more severe.
OS gap will decrease, then the MS severity will increase.
Severity is
So
increased.
tight MS. When there is absent OS, what that signifies?
Fixed.
What it signifies? Absent OS?
Calcified mitral valve.
Calcified fixed
Calcified mitral valve. Good. And what it signifies? Present opening snap. The valve is
valves is still pliable and
more pliable. A little bit more
valve is still
pliable.
pliable. Good. More pliable. What is the type of murmur? Can you describe the type of murmur in MS?
it is the low-pitched mid-diastolic rumbling murmur heard in the mitral area in the left lateral position at the height of expiration, which has a pre-systolic accentuation. With a pre-systolic accentuation of grade 3-4 intensity without any radiation.
What is the gradation of murmur? Anyone? What will be the type of murmur in mild MS? It will be mid-diastolic or something else? Mild MS?
Ma'am, late diastolic.
Early diastolic, not late diastolic. ঠিক করে বলো। Mild MS, there will be early diastolic and we may not hear the murmur. How will you hear the murmur in case of mild MS? We have to explore the area between apex and left sternal border. Because murmur may be localized to a very small area, okay?
Okay.
And in early MS, it can be heard after exercise also. In severe MS, how will be the murmur?
Severe MS, there will be after opening snap, there is rumbling type of murmur of grade
Hollow diastolic, পুরোটা জুড়েই
hollow
হবে severe MS with pre-systolic accentuation.
pre-systolic accentuation.
Or if there is associated MR, how will you understand?
This opening snap will disappear, ma'am.
Then anything else?
And
Opening
systolic
snap will
murmur
disappear.
appear
They
করবে
will
না MR থাকলে? MR থাকলে তো
radiation.
systolic murmur টা appear করবে along with the diastolic murmur, তাই না?
along systolic murmur, there will be muffling of the S2.
S1 will be soft and there will be no pre-systolic
Systolic
accentuation. Pre-systolic accentuation টা চলে যায় যদি MR থাকে সাথে। TR থাকলে কি হবে? If there is tricuspid agitation, what will happen?
There will be a systolic
murmur. Yes, good.
At the
Systolic
lower
murmur, where will
at
hear
the
it?
left lower sternal edge.
At the left lower sternal border. And at which time? during inspiration.
during inspiration.
And that is usually functional or organic?
Functional.
Functional.
Usually functional, not always, but usually it is functional. And there will be, what will be the symptoms? Parasternal heave থাকবে কি না?
Yes, ma'am. Parasternal, there will parasternal heave.
এয়ার থাকলে, অ্যাসোসিয়েটেড এয়ার থাকলে কি হবে?
Associated air থাকলে ma'am, we can hear the Austin Flint murmur
Murmur.
in the
আর
left second intercostal space.
Okay, if they associated with pulmonary hypertension,
Then we can hear in the pulmonic area, we will get a associated murmur.
loud P2 পাবে না?
Loud pit with
loud
with
P2
the loud.
পাবে, parasternal heave পাবে, তাই না? Pulmonary hypertension থাকলে পাবে তো?
Yes, ma'am.
আচ্ছা, associated right ventricular failure থাকলে কি পাবে?
We will have features like associated hepatomegaly, pedal edema,
মাথার থেকে শুরু করো,
engorged
neck veins will be distended, liver
neck
enlarged,
veins, engorged neck veins will be
then
present.
liver enlarged, peripheral, তারপরে হচ্ছে ascites, jaundice, peripheral edema, then there will be cardiac cachexia may be there. What is cardiac cachexia?
Ma'am, in severe cases of mitral stenosis where there is like heart failure present, the patients go into a catabolic state with which is
becomes?
causes like muscle wasting, weight loss, or like
That causes,
decreased
that is called
physical
cardiac cachexia.
ataxia.
Okay. And what are the other causes of diastolic murmur apart from the mitral stenosis here? Other causes of diastolic murmur. বলো।
Ma'am, besides diastolic murmur, we can have tricuspid stenosis. We
Aortic
can have
regurgitation.
like a Caricom's murmur, then Austin
Is that
Flint.
occurs in?
Caricom's murmur
in
will occur
rheumatic
in
fever.
like rheumatic
Rheumatic
valvulitis
fever.
because of acute inflammation of the anterior mitral leaflet. So Caricom's murmur we can have. Austin Flint murmur we can get in aortic insufficiency where the regurgitant flow will impinge upon the AML. Then we can have if we have shunts present, increased flow through that VSD or VSD and MR, we can get diastolic murmur.
Okay. And what is the differential diagnosis of mitral stenosis?
Other condition of mitral stenosis which mimics mitral stenosis are
mimic, yes. What are the differential diagnosis?
Left atrial
বলো।
myxoma, left atrial myxoma, then ball
myxoma
valve
then?
thrombus, then cord triatrium, supramitral annular, supramitral rings can mimic like mitral stenosis.
Are infective endocarditis with vegetation on the mitral valve.
Yes.
তাই তো? আচ্ছা, what are the causes of mitral stenosis?
Causes, one is rheumatic heart disease. Among the non-rheumatic, we have like
বলো। Rheumatic, and apart from rheumatic is
mitral
most
annular
common.
upon the non-rheumatic one, we have mitral annular calcification, then radiation associated mitral stenosis associated with degenerative disorders like SLE or mucopolysaccharidosis. Then
তুমি congenital গুলো তো বলো আগে।
yes, as part of the
আসবে না?
yes, as
What
the
are the
part of the
congenital
congenital
cause of mitral
spectrum,
stenosis?
as a
One
part
is
of the
parachute mitral valve. Another one is supravalvular mitral ring. Congenital এই দুটো হয়তো mitral stenosis এর মতন প্রেজেন্ট করতে পারে তো, parachute mitral valve. And what is parachute mitral valve? Orgo, what is parachute mitral valve?
Ma'am, the some part of the valve leaflet gets during diastole, the leaflet gets tethered to the LV, and
কি বলে
pre-
চলে
So the
এসছো?
chordae
What is
tendineous,
parachute
the
mitral
mitral
valve?
valve and parachute mitral valve, the chordae
These
tendineous
are
attached
attached
to
to
a
the single
single
papillary
capillary
single
muscle.
Single
muscle.
papillary muscle. Yes, that is the answer. Single papillary muscle is attached. Okay, to the
yes.
single papillary muscle attached. Okay. And what is the difference between chord atriatum and supramitral ring? How will you diagnose between the two? Chord triatriatum and supramitral ring. How will you diagnose this between the two?
There the in chord triatrium the ridge differentiating ridge would be
Where is the ridge?
above the
The ridge is above the
above
above the
the comorin ridge, above the
where is the
comorin
ridge? The ridge is above the left atrial appendage.
left atrial
And in
appendage and comorin ridge,
supramitral ring, the ridge will be below the left
below the
atrial
left atrial
appendage.
appendage.
So in chord triatrium, there are two chambers in the left atrium, and here there is one chamber with one small gap in supramitral ring. Okay. And what
Yes,
are the
ma'am.
systemic diseases that cause valvular stenosis? In mitral stenosis, what are the systemic diseases? দু একটা বলেছো প্রিয়াঙ্কা, বাকিগুলো বলো তো।
Systemic, ma'am, SLE, rheumatoid
SLE,
arthritis,
rheumatoid arthritis,
arthritis, mucopolysaccharidosis,
হ্যাঁ, হিল্ড এন্ডোকার্ডাইটিস, এন্ডোকার্ডাইটিস হয়েছিল সেটা ঠিক হয়ে গেছে। তারপর কার্সিনয়েড,
carcinoid.
severe mitral annular calcification, Lutembecker syndrome, and one drug that causes mitral stenosis. What is that drug? Methisargide. Methisargide may cause. Okay. Acha. What are the modified Jones criteria of rheumatic fever? Can anyone tell? Major and minor?
The major criteria include carditis, arthritis,
Polyarthritis, not arthritis. Polyarthritis, then
polyarthritis, Sydenham's chorea, subcutaneous nodules,
and erythema marginatum.
erythema marginatum. And the minor
And minor?
criteria includes fever, elevated ESR more than 60 mm or elevated CRP, polyarthralgia.
And increased? What is in the ECG? CRP
PR
more than
interval, increased PR interval.
will be
Increased.
increased. Okay. What about the evidence of streptococcal infection?
Ma'am,
Rising ASO titer. Rising ASO titer. থাকবে তো?
Ma'am, Jones criteria, the Duke's criteria.
Jones আসবে না, but what are the evidence of acute
Yes,
rheumatic carditis? Rising ASO titer.
titer, yes.
Or what are the echocardiographic evidence of acute rheumatic fever? Echocardiographic evidence of acute rheumatic fever. What are they? এটা তো পড়তে হবে, এটা তো জানতে হবে রে। Anyone?
Ma'am,
Vikrant, Ashish এরা আছে?
vegetations on the valvular leaflet infection.
Anything else? Anything else?
Pericardial effusion.
Mitral regurgitation seen in more than two views. Jet length more than 2 centimeter. Peak velocity more than 3 meter per second.
Yes.
Okay, and aortic regurgitation will be seen in more than 2 views. Jet length equal to or more than 1 centimeter. Peak velocity more than 3 meter per second. How will you diagnose acute rheumatic fever? Initial episode and subsequent episodes. Is there any other criteria to diagnose between the two? Acute rheumatic fever diagnosis. Initial episode. প্রথমবার rheumatic fever হয়েছে। কি করে তুমি diagnosis করবে among the major criteria and minor criteria?
Ma'am, blood cult.
মেজর ক্রাইটেরিয়া মাইনর ক্রাইটেরিয়া বললাম তো, তখন তোমার দুটো মেজর ক্রাইটেরিয়া অথবা একটা মেজর আর দুটো মাইনর ক্রাইটেরিয়া লাগবে। আর যদি সাবসিকুয়েন্ট হয় এআরএফ ডায়াগনোসিস কি করে করবে? যদি ধরো আগে একটা হিস্ট্রি রয়েছে রুমেটিক ফিভারের অথবা রুমেটিক ফিভারে, তো তুমি কি করে করবে যে হাই রিস্ক ফর
One major or
টু মেজর অথবা ওয়ান মেজর অ্যান্ড টু মাইনর? আর হোয়াট ইজ ডিউকস ক্রাইটেরিয়া? পুরোটা বলতে হবে না, কোথায় কাজ করে শুধু সেটুকুন বলো। ডিক্স
Ma'am,
ক্রাইটেরিয়া জিজ্ঞেস
Duke's
ডিক্স
criteria
ক্রাইটেরিয়া
is for like identifying infective endocarditis.
yes. Then tell me what are the latest guideline for IE prophylaxis, infective endocarditis prophylaxis.
Anyone, any MD students, you can answer. Anyone, please answer.
What are the latest guideline for ইনফেক্টিভ এন্ডোকার্ডাইটিস প্রোফাইল্যাক্সিস? একটা পেশেন্টের মাইট্রাল স্টেনোসিস, ধরো মাইট্রাল ভালভ রিপ্লেস হয়ে গেছে, সে তোমার কাছে এসছে 3 বছর বাদে, বা যে কোনো কমপ্লেন নিয়ে, মানে যে কোনো ভালভুলার হার্ট ডিজিজ পেশেন্ট এসছে, বা যে কোনো কনজেনিটাল ডিজিজ পেশেন্ট এসছে, কনজেনিটাল হার্ট ডিজিজ পেশেন্ট এসছে, কখন তুমি প্রোফাইল্যাক্সিস দেবে আর কখন দেবে না? এটা তো একটা গাইডলাইন আছে, এটা মনে রাখতে হবে। একটা হচ্ছে প্রস্থেটিক কার্ডিয়াক ভালভ যদি থাকে, ঠিক আছে, এমভিআর হয়ে গেছে পেশেন্ট তোমার কাছে এসে, ইউ হ্যাভ টু গিভ দ্যাট। যদি হিস্ট্রি অফ ইনফেক্টিভ এন্ডোকার্ডাইটিস থাকে পেশেন্ট, ইউ হ্যাভ টু গিভ। ওকে, কনজেনিটাল হার্ট ডিজিজের ক্ষেত্রে কখন দেবে? ইফ দেয়ার ইজ আনরিপেয়ার্ড, যদি সেখানে প্যালিয়েটিভ শান্ট বা কন্ডুইটস থাকে, কমপ্লিটলি রিপেয়ার্ড কনজেনিটাল হার্ট ডিফেক্ট যদি থাকে উইথ প্রস্থেটিক মেটেরিয়াল অর ডিভাইস, সেক্ষেত্রে প্রথম 6 মাস দিতে হবে, তারপরে আর লাগে না। আর যদি রিপেয়ার্ড কনজেনিটাল হার্ট ডিজিজ হয় তাহলে উইথ রেসিডুয়াল ডিফেক্টস তখন দিতে হবে। আর কখন দেবে? কার্ডিয়াক ট্রান্সপ্লান্টেশন রিসিপিয়েন্ট উইথ কার্ডিয়াক ভালভুলার ডিজিজ। What
Okay.
are the investigations you need to assess the patient?
For this patient, we will have the laboratory blood investigation, which includes complete hemogram, liver function test, renal function test, electrolytes.
Why
We
you
can,
go for liver function test?
because there may be associated right heart failure, which will represent, which will show alterations in the LFT.
Okay. Then what are the other investigations you will do?
The RFT, serum electrolytes. Then we can have a CRP and an ASO titer.
Why serum electrolyte is important for these patients? Most of the patients receive diuretic. That's why it is important. Yeah. Then
We can have an ASO titer and a CRP, and in the complete hemogram, we can also see the ESR specifically. Then the other investigations will include the radiological will include the chest X-ray and ECG, and in case of elderly patient, we can also go for a coronary angiogram and a 2D X-ray, ECG, and
ওটাই বাদ
a
দিয়ে গেলে ইকো
transthoracic
বলবে
echo.
না? Chest X-ray,
Transthoracic
ECG,
echo.
ইকো বলবে তো?
Transthoracic echo, and in elderly patient, we can also
Go
with
for coronary angiogram.
angiogram.
What is the age limit for coronary angio for mitral stenosis or any this type of patients?
Ma'am,
When you will go for
above
coronary
40
angio?
years, we usually get a CAG done.
40 years in male or female?
Female.
40 years in female. ঠিক করে বলো। Above 40 years in male and 45 years in female. Okay.
Okay.
And what will you get in chest X-ray?
Ma'am, in chest X-ray, first we can see get an
Chest X-ray is not a good
cardiac.
one. এটা কি
Yes.
অ্যাসোসিয়েটেড এমআর আছে নাকি রে এই পেশেন্টের?
না, এই পেশেন্টের ছিল না, এই এক্সরেটা আমি পেয়েছি।
কোথা থেকে নিয়েছো? শুধু এমএস বলেছে?
হ্যাঁ, শুধু এমএস।
আচ্ছা।
There may be a cardiac enlargement predominantly because of the RVH. There can be straightening of the left border of the heart, a small left border of the heart, a prominent pulmonary pulmonary bay because of pulmonary hypertension. Then features of there will be a double-sided right contour of the heart where the outer border is
And
formed
RA
by the
enlargement
LA
is there
enlargement.
in this X-ray? হ্যাঁ।
Yes, sir. The outer border is formed by the enlarged LA and the inner border is formed by the RA. In the lung fields, we can have if there
That
is
depends, Priyanka. That depends. RA may form the outer border, RA may form the inner border. Which which one, which chamber is enlarged more? That will form the inner and outer border. Okay.
okay.
Don't commit. This is LA and this is RA. Okay.
Okay, so just double contour of the right heart of the right heart of
Formed
the
by LA border and RA
Then
border. That's
in
fine.
the
In the
then on tracing the trachea, if there is LA enlargement, we can have a splaying of carina. the prominence of the upper pulmonary veins, if present, that indicates presence of pulmonary venous hypertension. Then increased vascularity at the parahilar region will show, and prominent of the pulmonary arteries will indicate pulmonary arterial hypertension, and presence of B lines, Curly's B lines towards the basal level also goes in favor of associated pulmonary hypertension.
What is cephalization in this X-ray? Is it there? Cephalization?
No, ma'am, not very.
What is cephalization? What is
Cephalization.
cephalization?
Cephalization of the means
I can
the
see here cephalization. Why you are not telling? Cephalization is not there. দেখো নিচেরটা দেখো সাদা সাদা টাইপের, ওপরেরটা দেখো বেশি কালো, কেন হয়েছে এটা? That is cephalization. Why? Why cephalization occurs? When the hydrostatic pressure is more than 10 millimeter mercury, what happens? Fluid comes to the interstitium of lung. Okay, and edema fluid, as it is fluid, it will come down. That will compress the lower part of the vessels, and so blood will go to the upper part of the lung by the upper part vessels. Okay, that is called the cephalization. মানে উপরের দিকটা একটু কালো কালো হবে, নিচের দিকটা একটু হোয়াইটিশ হবে। এখানে সেটা আছে তো, নিচের দিকটা একটু হোয়াইটিশ।
নিচের দিকটা হ্যাঁ হোয়াইটিশ আছে, উপরের দিকটা তো কিছু
একটু একটু দেখো সামান্য হলেও আছে, কিন্তু একটু নিচেটা একটু না, বড় করলে আবার অতটা লাগছে না। যাই হোক, দ্যাট ইজ cephalization. ওকে
ওকে ম্যাম।
আচ্ছা, হোয়াট ইজ Carley's ABC lines? বলো বলো।
Ma'am, Curly's lines.
There are 3 types of Carley's line, ABC.
Yes,
What are they?
Curly's lines, they basically findings on the chest radiograph which denote pulmonary edema or lymphatic enlargement. So Curly
Yes.
A and B line, Curly A lines are normal, which is seen, which is
From
like a
hilar
long
to
linear.
periphery. From
They're
hilar
like
to periphery.
from the lung periphery to the hilar, and curly B lines also extend toward, they are found in towards the base of the B represents base, so they are like horizontal lines which is found in the
And they are very small, less
periphery.
than 1 centimeter in length, and they are due to interlobular septa, Carley's B line, and they are parallel to one another, Carley's B line.
Yes.
Due to what they are due to?
They are due to pulmonary edema.
Yes, good. What is Carley's C line?
They are like short lines, which unlike the B or A lines, they will not reach the. They will move radially from the hilar, and they will. They will.
They are very short and fine lines, and they cannot be seen without the Carley's A and B lines.
Yes.
Right?
Yes, ma'am.
They are very rarely seen. And what is about ECG?
Ma'am, just to interfere, after this discussion, ma'am, we can continue this discussion in the next class because it is.
হ্যাঁ
just
ঠিক আছে,
around-
ইসিজিটা করে নেই না, ইসিজিটা
হ্যাঁ
ছেড়ে
হ্যাঁ
দেবো।
ইসিজিটা করে নিন ম্যাডাম, ইসিজিটা শেষ
না,
করে
যদি বলো
তারপরে
ইসিজিটা ছেড়ে দিই, পরের দিন করবো।
ইসিজিটা করে নিন স্যার।
করে দেবো। আচ্ছা ঠিক আছে, বলো প্রিয়াঙ্কা, হোয়াট ইজ অ্যাবাউট ইসিজি?
In the ECG, we can, if the patient is in sinus rhythm, then we can get this kind of an ECG where the predominant finding is basically this bifid P wave seen in the lead 2 and a biphasic P
Is
wave.
bifid in mitral stenosis?
Because of the P wave is a composite wave which represents the
LA and RA enlargement.
both
And
LA
because
RA
of the
enlargement.
enlargement, that takes time to go from one atrium
Yes.
to another atrium. So there is
we get a
notch
bifid
between the two.
notch between the two. And also in the P1, we'll get a biphasic P wave because of the LA enlargement. And had the patient been not in sinus rhythm, then we would have got features of we would have got features of atrial fibrillation with control rate, absence of P waves. And here, though there is no sign of RVH, so we can also get an associated feature of RVH, which includes a large R in V1 more than 7 millimeter, or a combined RNS of 10 millimeter, and deep S waves in the V5 and the V6.
Okay. Okay. That is about the ECG. So we can finish here. We can complete here, Mona Lisa.
Ma'am, we can continue in our next class.